So this chapter here covers the chapter 36, central nervous system stimulants and attention deficit hyperactivity disorder. So again, starting off with a sort of pharmacotherapy of ADHD and why amphetamines, are utilized for these individuals is again going back to some alteration in specific neurochemicals. In particular for ADHD, it's going to be these children have shown sort of a decreased or erratic production of norepinephrine. So it results in inefficient spikes in the neurochemical, which keeps it from being able to sustain attention and concentration, much like we talked about with the with mania in terms of it not being able to complete its full sort of action potential, so it's sort of erratically firing, and it causes the ability to maintain focus, causes irritability, causes concentration issues, and the other neurochemical that's of interest there is going to be an inefficient production or reduced production of dopamine, which means that we know the dopamine it is a pleasure principle, so when dopamine goes up, it sort of reinforces our sort of propensity to do something. And so without the dopamine there, if someone's performing a task and there's no neurochemical reinforcement to continue to perform something that they may or may not enjoy. So if you paint, people enjoy sitting there doing that, but the dopamine is being sort of produced, so you got that attachment, that sort of pleasure principle that sort of goes along with that, whereas someone with ADHD, they don't have that, they're not able to develop that type of attachment because there's not as much associated pleasure. Couple that with the erratic sort of norepinephrine, and you get someone that's sort of all over the place and an ability to sit still and concentrate. And so we use amphetamines because they, again, would function based on those two neurochemicals. So in theory, for people with ADHD, the norepinephrine and dopamine sits below what we would consider to be normal. So if mine's up here, and this is, well, not mine, but normal is here, then you assume that someone that's ADHD is here. So if I were to take amphetamines, norepinephrine, then I'm going to end up going way up here, which is going to cause me to get high. I'm going to end up getting, sort of excessive effects from amphetamine, what people that actually do abuse crystal meth and amphetamine actually get from it. Whereas if this is going back to where normally they should be, and ADHD children are right here, then what it does is bring them back up to what we consider to be normal. So for normal concentration, normal attention span, normal attachments to certain activities, and the ability to sort of regulate their things. So there's a couple of different sort of amphetamines. There's a lot of different combinations, so it can be a little bit confusing. Again, your book covers them pretty well. I'm going to cover just very, very quickly, and then I'm going to talk about sort of the side effects to that. But amphetamines typically used, of course, for ADHD, and also you may see them for insomnia. The idea behind that is to basically give it to them in the daytime to where they're really exhausted neurochemically and physically by the end of the day, so they're able to actually sleep. For use for obesity, because we know that amphetamines, norepinephrine when it goes up, is a appetite suppressant. So it can be used for that as well. There's a couple different combinations of amphetamine. 50 is a mix of dextroamphetamine and levamphetamine. You got dextroamphetamine, which is just dextroamphetamine or dexedrine. Then you got methamphetamine, which is dextro plus a methyl group like a CH3. Then you got amphetamine mixture, which is Adderall. Then you've got methylphenidate, which is Ritalin, which is short-acting. Then you've got the long version of methylphenidate, which is Concerta. Then you've got lisdexamphetamine, which is Vinase, which is a prodrug to dextroamphetamine. And so when you have something like a prodrug, usually you have a better side effect profile with that, but you usually offset the better side effect profile with it being not as effective. With Vinase, there's less of a high associated with taking them, and you don't have a lot of the excess amphetamine stuff. So you don't have as much juriness, you don't have as much anxiety and things like that you may have someone that takes too much of the amphetamine. Vinase has a sort of a regulatory control of that, which is why it's usually preferred. And it doesn't tend to be quite as effective in severe ADHD, but overall it's fairly effective and less addicting. Then you got Pimlin or Cylert, and then you've got the street drug, which is the 3,4-methylene dioxymethamphetamine, which is MDA or ecstasy. So you may see these not necessarily in a controlled capacity in terms of pharmacotherapy, but in the form of illegal drugs, crystal meth, ecstasy. So some of the same sort of side effects and things apply. So one thing to remember about a lot of these different sort of neurochemicals is if you can understand what type of effect they have in terms of sympathetic versus parasympathetic, you can actually predict a lot of side effects and things you should be looking for. So, for instance, with GABA, it's a common agent, so we know that's sort of parasympathetic. So, whenever you introduce GABA into the body, you can think that all the side effects you're going to get from that medication are going to be parasympathetic oriented. So, if you're using medications that are more sympathomimetic, sort of like an Adderall, then you're going to expect the symptoms to look more like your sympathetic nervous system is being provoked, because that's exactly what's happening. So, when you think about people taking Adderall and the side effects, it's going to be the same thing you would expect from someone that's running from a bear. So, all the things that would go along with like physical activity in terms of running, in terms of fear for the fight or flight thing, without an actual threat in place. So keep that in mind. Amphetamines are well absorbed in the GI tract. They're excreted basically unchanged in the kidneys, so they continue to exert an effect, until they're cleared, actually. Indirect acting, like I said, sympathomimetics, they cause release of norepinephrine in the nerve endings, and they block reuptake of the norepinephrine nerve endings. They increase dopamine by blocking reuptake and also stimulate excess release of dopamine. They also retard the enzymatic breakdown of dopamine, so that's why there's more available. So we had talked about in the antipsychotic that where the dopamine tracks were the mesocortical, the mesolimbic, the tuberoinfundibular, and the nigrostriatal. Well, we were reducing dopamine in those pathways. Now we're actually producing dopamine in the exact same pathway. So you actually, in excess, you're going to get a lot of the same sort of side effects or behaviors that you might get from someone that is manic or someone that is psychotic. And that if you take too much amphetamine, you can get the hallucinations, the paranoia, and illusions, which is why you see sort of like on TV when people that are on crystal meth, they have the behavior that they do. So these things are all very related. It's beyond sort of the design of these videos to sort of cover those things. But if any of you guys are interested in sort of the more neurochemical aspects of this and sort of why these things work, if you can learn those, you can actually predict and be able to prescribe better a lot of these psychotropics. But just know that the CNS effects of amphetamines are going to be wakefulness, alertness, heightened awareness, and concentration, increased energy, and at times insomnia, which is sort of counterintuitive because we can use it for insomnia as well. And you have amnesia, which is basically from overactivation usually. You think about the sympathetic nervous system, you think about it when you're very fixated on things like with the bear, you're not really attending to sort of the peripheral things that are going on, and you're going to have less of a memory around sort of the wooded area that you may be running from a bear, but you're going to remember things about the bear. So the amnesia actually comes into sort of hyperstimulation or forgetting things that were not directly involved with your focus point, which is something that we do naturally with our brain, is we attend to multiple things. So it kind of limits that and narrows your memory in a lot of ways. The PNS effects are palpitations, tachycardia, and hypertension, which you expect. So the main systems of interest when you're evaluating for amphetamines is going to be cardiovascular, then followed by respiratory. So mild to moderate symptoms of overdose of amphetamine, which is something important to consider both in the illicit drug use and also in the ADHD population, is abnormal heartbeat, high or low blood pressure. In extreme overdose, you're going to think about cardiogenic shock, cerebral hemorrhage, and circulatory collapse. Central nervous system, you can have some confusion, abnormally fast reflexes, amphetamine psychosis, compulsive and repetitive movement. So you've seen people that are on amphetamines, or I would assume on TV they pick at their skin. That's some of that obsessive compulsive stuff. In addition to, it's also related to a lot of the junk that goes into crystal meth, all of the battery acid and stuff is being excreted from your skin, so it causes a breakdown and gives them sort of a fixation point. You also can get severe agitation, tremor, serotonin syndrome. So I mentioned earlier in the antidepressant thing that if you take Adderall or something with an SSRI, the potential exists for you to have serotonin syndrome. So remember the effects of that, the hyperreflexes, the hypothermia, and evaluate. And don't confuse the two, because sometimes they do look very, very similar. And then you get the sympathomimetic toxidrome, which is going to be just excessive adrenergic activity, which makes sense because you're increasing the norepinephrine. Musculoskeletal muscle pain, rhabdomyolysis. So you can get a breakdown of muscle. You got to watch the cardiovascular system for that, because it breaks down creatinine, and it's because they're moving around so much is part of that. So in addition to the neurochemical processes behind it, the muscle breakdown is because they're just so active. Respiratory rapid breathing, and then extreme overdose, you're going to get pulmonary edema, pulmonary hypertension, and respiratory alkalosis. Then with urinary, painful urination, urinary retention, no urine production, and kidney failure. So if you think about it in terms of sympathetic, again, going back to the kidney, if you're running from a bear, it doesn't make a lot of sense for you to stop and urinate. So your body's going to sort of control that through vasculature. So again, think about cardiovascular with amphetamine. Then you've got elevated body temperature, which again is going to be a dysregulation between dopamine and serotonin. In the overdose form, you can have hyperpyrexia, elevated or low potassium, which again makes sense with the heart, and then metabolic acidosis. The other things to keep in mind with ADHD in terms of the treatment is I think we're all pretty familiar with sort of the diagnostic criteria of that, especially with the hyperactivity. There are non-narcotic ways to treat ADHD. Amoxicillin and Strattera, and the books and PowerPoint does a pretty good job of sort of explaining those. Then you also have the alpha-2 agonists such as clonidine, catapress, and guanfacine 10x. And those drugs work by sort of tricking the brain into thinking there's adequate amounts of norepinephrine in the brain, and it results in a lower level of norepinephrine synthesis and release. So, I mentioned earlier where, normally you're here, and then people with ADHD are down here. So it kind of tricks the brain into thinking that the norepinephrine is normal, and that's sort of why that works.